I'm Dr. Fiona Lovely, and this is the Not Your Mother's Menopause podcast. I'm taking the taboos of menopause and peri-menopause and bringing light to the dark. No bullshit, no shame. It's time for us to gain a new paradigm in female health, out with the old and in with the new, and I'm bringing fresh perspectives from someone in the arena. I've been practicing women's health for nearly 20 years, and I'm spilling the tea on what it means to live at midlife, knowing that the best is yet to come. I'm sharing my Gen X approach to living through this transition. Sassy, a bit sweary, and always honest. Tactical tips and instantly usable information is my aim. I hope to make you laugh and that you learn something new that helps you embrace the change. Together, we bring power to the peri. Onward to the podcast. You're tuned in to the Not Your Mother's Menopause podcast. I'm Dr. Fiona Lovely, and I'm so glad you're here with me today. This episode, I'm super excited for you to listen to this conversation between me and my friend, nurse practitioner Shelby Sheppard. Every so often, you meet someone in this world, in this work, who just gets it. Someone whose whole approach to caring for women makes you exhale and think, oh, good, you're one of us. Nurse practitioner Shelby Sheppard is someone who gets it. This is not a neutral, arm's length introduction. I absolutely adore her. I refer my own patients to her, and I have learned things from her that made me better at what I do. So you're getting me kind of as a fan today. Let me tell you about Shelby. My guest today is Shelby Sheppard. She is a nurse practitioner and the founder of Pause Health, a virtual hormone and sexual wellness clinic. She earned her Bachelor of Nursing from Memorial University of Newfoundland and then went on to complete her Master of Nursing as a nurse practitioner in primary care at the University of Saskatchewan. And across the whole arc of her career, she has planted herself right at that intersection that is so close to my heart. Women's health and care that's evidence-informed and deeply, genuinely personalized. One of the things I love most about Shelby is that the idea that her whole practice is built around. She believes, and I'm quoting her here, that normal isn't optimal. Let that sit with you for a second. Normal isn't optimal. How many of us have been told our labs are normal, our symptoms are normal, that this is just what we should expect now at this point in our lives? Well, we sit here knowing in our bones that we do not feel like ourselves. Shelby built Pause Health to be the answer to that, a place with longer appointments, deeper conversations, the kind of individualized support that women navigating perimenopause, menopause, and hormonal change have been quietly begging for and so rarely get. She holds advanced training through WorldLink Medical and hormone therapy and in sexual health, and her clinical focus is right in the thick of the conversations we have on the show all the time. Menopause hormone therapy, testosterone optimization, the genitourinary syndrome of menopause, and sexual wellness. We're going to get into all of that today and so much more. And I promise you, she's so good on these topics, you're going to want a notebook. But I want to tell you why she really matters to me beyond the credentials. Shelby is one of the people I trust with the women I care about. When I have a patient who needs a particular kind of expertise, Shelby is a name I say out loud with complete confidence and daily in my practice. And the feedback I get is always the same. They felt heard. They felt like someone finally took the time. That's rare. And it's precious, and it's exactly what this whole field needs more of. She is also on a mission I share completely, closing the gap in menopause care access and empowering women to advocate for themselves, because she believes, as I do, that every single woman deserves to feel and function at her best at every stage of her life. That's not a marketing line for her. That's the engine beneath everything she does. And that's where we're headed today. We're going to talk about hormones. We're going to talk about testosterone, which, fair warning, is one of her favorite subjects. We're going to talk about thyroid. We're going to talk about GLP-1s. We're going to talk about sexual wellness. We're going to talk about progesterone for postpartum depression. We're going to talk about what libido and sexual wellness means at menopause for women. And we're going to go into all the places where women have been handed a story that's far too small for us. This is a warm and honest conversation, and we laugh lots too. Before we dive in, one quick thing. If you're not getting my newsletter, I'd love to have you join us for the bi-weekly Fiona's Friday Favorites. It comes out twice a month. It is absolutely full of helpful things, the resources, the reads, the little discoveries I want to put directly into your hands. You can sign up over at drlovely.com. That's drlovely.com. Go do it now. I'll wait. Then come back because you don't want to miss this conversation. All right, let's get into it. Please join me in welcoming the wonderful nurse practitioner, Shelby Sheppard. If your energy levels feel low and you're experiencing digestive issues like gas and bloating, even when eating healthy, nutritious foods, imagine how you might feel during the indulgence of the holiday season. Adding a high-quality enzyme supplement to your routine could make a big difference. I personally recommend Masszymes by Bioptimizers. It's a best-in-class supplement loaded with full-spectrum enzymes for digesting proteins, starches, sugars, fibers, and fats. After you start taking Masszymes, you may notice that you no longer feel bloated after meals and that your belly feels flatter. These powerful enzymes boost your energy by increasing metabolism of your food for fuel. And by improving digestion, your body has more resources to allocate for mental and cognitive function. I can definitely vouch for these enzymes. I take them myself, and they are powerful. For the entire month of November, Bioptimizers, the makers of Masszymes, are having a Black Friday sale, their best sale of the year. All month long, you'll get discounts with my unique code, plus access to up to $100 in free gifts with purchase. You can only get this exclusive deal through my link, special for the audience of the Not Your Mother's Menopause podcast. You won't find this on Amazon or even on the company website. Go to bioptimizers.com/lovely and use code LOVELY to get your discount and free gifts today. All Bioptimizer supplements are best in class. If you don't agree, you can get a full refund for up to 1 year after your purchase, no questions asked. Again, the link to go to right now for this exclusive deal is bioptimizers.com/lovely using the code LOVELY, links in the show notes. This is the Not Your Mother's Menopause podcast. I'm Dr. Fiona Lovely, and today I've got a friend on the show with me today, nurse practitioner Shelby Sheppard, the rock star nurse practitioner who's been taking care of my patients for a few years now. Shelby, I'm so excited to have you on the show. Thanks for joining me.
Yeah, no, thank you for having me. I am super excited for this conversation today.
Well, I've had the thought that someone should be listening in when you and I are talking because we get into it. We dig down.
We do.
We really do, which is fun. And in fact, we're just going to open that aperture a little bit today so that the women in my community can listen to your brilliance and your expertise and what you've seen in the trenches as a midlife. I don't know. What do you call yourself? A hormone expert? I know you say sexual wellness in there. And of course, you're a nurse practitioner, so you're a prescriber and an advocate for us. How do you define what you do?
Yeah, I am a nurse practitioner. So I have a master's in nursing, nurse practitioner. My designation was in primary care, but I've really transitioned into helping women through midlife and any other hormonal conditions, whether it's PMS, PMOS now.
Yay!
Or, low testosterone, fatigue, thyroid issues, and any sexual dysfunction. So that's really how I describe myself.
Okay, I love it. So I've come to know you as an expert at all things that we need to know about at midlife, which is extraordinary. And I thought maybe I'd share with the listeners the story of how we came to know each other, because I think it's a really good demonstrator of your expertise for sure. I had a chiropractic patient say to me, so a few years ago now, she was pregnant with her second child, and she asked me if I knew whether or not a woman could take hormones to help with postpartum depression, which I think has a different name now, doesn't it?
I don't know. I think we're still referring to it as postpartum depression.
Okay.
Yeah.
So postpartum depression, she apparently suffered quite significantly with her first child and was wondering. And I thought, huh, that's interesting. Of course, what I work with is women in midlife, generally, menopause, and I'd never thought about postpartum. And she asked me if I knew anybody that could have that conversation. I said, well, you're going to need a prescriber that's open minded. Do you happen to know a nurse practitioner? And she said, actually, I do. And of course, you guys had a fitness class together, and that's apparently when she reached out to you. And from my end of the story, what I heard from her was that you said, absolutely, we want to prescribe progesterone to women after, like after delivery, and then you titer it down over a month's time. It was like 3 weeks or something like that, that she described to me. And that's why I'll let you take over the story from this part.
Yeah, I love that that's how we met because it really started our relationship, I think, around hormones and how we have to think outside the box and how we have to trust women to make decisions for themselves. And for me, I had done some training in the US at WorldLink Medical where they had talked about how to manage postpartum depression and anxiety and even means to do it sort of prophylactically. So, where you prescribe it at birth, progesterone, micronized progesterone, I'm talking about. So, you prescribe that at birth at high doses and then titrate it down over the course of time. And unfortunately, I would love to see a ton of more research and randomized control trials in this area, but will we see it? I don't know. But to me, physiologically, it made sense, right? It was plausible, right? Where what happens is when you're pregnant, you have very, very high levels of progesterone in your body. And when you deliver that placenta, those hormone levels go from extremely high to nothing really quickly. And that significant drop can have a profound effect on how someone feels. And then you add in sleep deprivation, breastfeeding, and becoming a new mom, that change in identity. And it can be hugely impactful. And so using something like progesterone and starting it at a high dose and titrating it down slowly over the course of usually, I think it was kind of 4, 5, 6 weeks. It really depended on the slowness of that trajectory. But titrating it slowly over time, instead of having that gigantic high, low crash, we had a slow taper down. And there have been some great studies, they're older studies, 80s, 90s, where they used different forms of progesterone to treat postpartum depression and anxiety. But for whatever reason, I think it's an area that has been under-researched, underfunded. I think estrogen could be quite beneficial, but unfortunately that does impact breast milk, or at least what we know so in the data so far. And I think overall, the challenge is that women should be able to make informed decisions that work for them. And at the end of the day, this person came to me and said, look, this is what I'm worried about. This is what I'm struggling with. Do you think this could help? And yeah, there is research that suggests it could be beneficial. And so we thought we would give it a try because for her, those benefits outweighed the risks. And as you know, it was actually a really great outcome for her. So
Yeah.
it's something that, I'm a big advocate for women being able to make decisions that feel right for them.
Yeah, absolutely. And I do remember the patient that we're talking about saying that she did have a really good experience with it, but that the obstetrician found out or about it sometime after, I don't know, a week or two in and said, that's ridiculous. Come off that immediately. Like now, Shelby, you and I hear these things all the time, unfortunately,
Mhm.
from Western medicine. And of course, you're inside Western medicine, so we can talk about that a little bit. But
Mhm.
I don't know. I don't know how you feel about it, but that doesn't even phase me anymore. Like when I hear that a medical professional is having a strong reaction, I'm like, okay, we must be onto something. We're deep in it now. So let's find out like is this working? What's working here, etc. What do you think?
Yeah, I used to be quite bothered, I think, earlier on in my career, but now I just know the research so well. I know the ins and outs of it. And I also recognize that we're not going to have a randomized control trial for everything because they're expensive and they're time intensive. And we're we have to also think what makes sense, critically think, like, is something plausible? Does it make sense physiologically? If we go back to the basics, do things make sense? And then also just looking at what am I afraid of? Like, if I do this, what am I afraid is going to happen? What is the worst outcome if I gave someone, in this example, progesterone postpartum? What is the worst thing that's going to happen? And then allowing that patient to see that, understand that, and then come to a decision of if they want to try it, great. And if they don't, well, that's okay too, because that's a treatment decision too.
Yeah, absolutely. Well, and in this case, it was really helpful. I learned a lot in the process. I know the patient did as well too. And so thank you for being that person. When I heard that she had written you that prescription, I asked her if she would introduce me to you. And that's how we
Mhm.
met. And I certainly remember those first few phone calls we had together because I think you were either just having your first child or it was you were
Mhm.
pregnant with your first child, right?
Yep. Yep.
And so we would get on the phone because trying to get two healthcare providers together in person, forget it.
Yeah. No, absolutely.
Is harder than it and I just remember I have notes from some of those because in a way, I was interviewing you. It was sort of a long
Mhm.
interview process, like, "Can I
Mhm.
send my people to you? Do you
Mhm.
have the skills, the knowledge, the
Mhm.
tools, the openness to look
Mhm.
at menopause and perimenopause in a way that our GPs are not, even our gynecologists are not being taught about?"
Absolutely. And I remember I was actually in the process of starting my own practice at that time too. So not only was I going through the life change of being pregnant and navigating that, but I was also starting a business. So we met during just like this really awesome time. And yeah, I'm so grateful for that.
Oh, yes, me too, me too. Okay, like, I remember interviewing you going deep on the thyroid in particular. Shelby, there's so many blind spots in women's medicine, so many. But
Hmm.
I think one of the most impactful, and I don't mean in a good way, is the way we sort of blindly look for one facet of thyroid disease, which is extremely common. We look for one facet of it, and if that facet doesn't show up as irregular in some way, I'm talking about TSH now, then we
Yeah.
just kind of move on. We don't look at the other elements of thyroid health. So, can you talk about thyroid health a little bit and what you see?
Yeah, absolutely. And I agree. I think my thought process is why are we basing everything off of one singular lab test? And TSH, if for anyone who doesn't know, is thyroid stimulating hormone. It's a hormone produced by the brain that tells the thyroid gland to produce thyroid hormones. Free T3 and free T4 are other measurements of those thyroid hormones that we can get that give us another indicator of what's going on with the thyroid. The other thing are antibodies, because sometimes our body starts to attack our thyroid gland before we actually see changes show up in that TSH level as well. And then I think we also have to consider symptoms in that whole picture. And we've actually changed, which I actually had this conversation with a physician recently about why on earth do we change lab norms on a regular basis? It used to be the TSH cutoff was 4, and now it's up to 6.5. And do people feel better between 4 and 6.5? I don't know. So it's like sometimes we make these arbitrary changes and we don't factor in the patient sitting in front of us and how is that person feeling. And I think that thyroid has such a profound impact on our metabolism, how we feel and function day to day, fatigue, our mood. There's so many things that thyroid does have an impact or a pulse on. And I think that when we just look at TSH, we're missing like a much bigger picture. And I've had physicians and other colleagues say to me that, oh, well, there's no point in measuring T3 and T4 because they can't be abnormal if you have a normal TSH. And I actually saw that happen yesterday in my practice. So I can guarantee you when you are ordering all of these panels, you will see changes in free T3 and free T4, even with a normal TSH. It happens all the time. And when you are able to do that, you're able to offer patients better treatment options, I think.
Mhm. And I think the conversation doesn't just stop at Synthroid. Unfortunately, that's where
Hmm.
I see it go so many times. And I remember years ago, okay, so for a little
Hmm.
historical perspective for everybody listening, one of the first pharmaceuticals was something called Armour Thyroid, which is actually porcine thyroid tissue,
Hmm.
meaning the tissue from a pig's gland. Now, human physiology and porcine physiology are very similar, and there's a whole thing with that in diabetes in particular. Diabetes research, etc., is often done with pigs. Anyways, so I remember being a young clinician and, being full of it, literally, and being at a St. Patrick's Day party with one of the most well-known endocrinologists in Colorado at the time.
Wow.
And I may have been socially lubricated in such a fashion, and so is he, that I went and approached him and I said, please tell me why Armour Thyroid has fallen out of favor for Synthroid. Because Synthroid, especially
Mhm.
long-term Synthroid, has some side effects that should not be ignored. Bone loss is one of them, and a major
Mhm.
depressive episode is the other one. And so,
Mhm.
why are we not just giving women the actual thyroid tissue that can do the same thing? And he
Mhm.
said in a slurred fashion, we can't trust people to take their medication twice a day. Where a Synthroid, you only have to dose once, where the actual Armour Thyroid is twice a day. So I was like, "Really? And so we're gonna give women major side effects because we think they can't take their medication twice a day?" Have you ever heard anything like that? Isn't that absurd?
Well, I'm not surprised. Nothing surprises me anymore. But like we have a million blood pressure medications, we have a million SSRI medications for mood, anxiety. Why do we only have one option for thyroid, right? So why? I always think we need to give patients the menu option of different combinations. So whether it's TSH with T3 like Cytomel, or if it's again desiccated thyroid, or what option works for them and their lifestyle and what their goals, preferences are. Obviously for some religious backgrounds, for some thyroid is not an option. So
Mhm.
when we limit it to just one medication, we're really doing people a disservice. And I always think about the book. I don't know if you've heard of it, Rethinking Hypothyroidism by
Mm.
Dr. Bianco. He used to be the president of the American Thyroid Association, endocrinologist, and he has fascinating work. He talks a lot about the fact that, the history of thyroid, kind of what you talked about, and Synthroid coming on the market. But what I thought was really interesting is he obviously was prescribing a ton of Synthroid, and he was having patients come back saying, I don't feel good. And they were testing their lab values and they were normal. And so he would say, well, it's not your thyroid, it's something else. And these patients would go off and see some other provider that was open minded to trying a different option with them, including T3, because we know Synthroid's only T4, which is the inactive form of thyroid. T3 is the active form. The reason being is T4 is much longer lasting in the body. The active form is very short acting. So that's the means of why. And the thought process is basically you have these iodine molecules, there's four of them, and you cleave off one and you have three, and that's the active form. So you give someone T4, and the body's supposed to do that process where it breaks it down. So he, through his research, has kind of, hypothesized that maybe some people just can't do that process, or maybe the receptors aren't as sensitive to the medications. So these patients would come back who've seen another provider, got T3 in addition to T4, or got desiccated thyroid and felt better. And he said, well, how can I argue with that? Right? Like that's the patient's experience. So that he was curious. He looked into it and he started thinking, well, maybe Synthroid isn't for everyone. Like, despite the marketing that said T4 should be able to be converted to T3 by everyone and it should work for everyone. Well, we know we're all individuals. Our bodies act so differently. And I just really love his work because it just emphasizes the fact that just because it works for someone doesn't mean it works for everyone.
Mhm.
And we have to look at more than just the blood test itself because we have receptors. How sensitive are our receptors to medication? Can our body actually go through that process that breaks that molecule down into what we need? So it's a very fascinating read for anyone who's into thyroid, but basically I just think when we focus on one option, we really do patients a disservice.
Yeah, absolutely. And this is one of those places, again, where thyroid disorders and thyroid diseases are primarily a female disease.
Hmm.
And so, again, we're seeing another blank spot where the research hasn't been there. It's just like, oh, we've got a medication that's fine. We don't need to look at anything else. And
Hmm.
just so many places that we can look. I love what you said there because, again, we want to consider all aspects. The antibodies get ignored quite often, and that's a
Hmm.
really important thing to look at because it can be the first sign of autoimmunity in the body, which is one of those things that you want to pay attention to. Of course, we can help to control autoimmunity through our diet and our lifestyle and pull those levers of stress reduction, etc., rather than just saying, "Oh, you've got this, here's your medication for the rest of your life," without really understanding what it means to have autoimmune disease of, again, thyroid is usually the one that's found first, but those Hashimoto, we're talking about Hashimoto's thyroiditis, by the
Hmm.
way, for those that are listening. Okay, let's take a bit of a right turn here. And where do we go next? I mean, let's talk about PCOS and how it recently was renamed
Hmm.
polyendocrine metabolic ovarian syndrome,
Hmm.
PMOS. Yeah. What do you think?
Hmm. Yeah, I think it is the first step towards recognizing what this disease actually is, and hopefully will be the thing that opens the doors to many more women getting that diagnosis and that treatment. Because, and even I had a conversation with a patient yesterday, so this is so fresh in my brain, of they were actually fortunate to get the diagnosis in their 20s or in their 40s now, but nothing was done with it. Until they wanted to get pregnant, nothing really was considered. They weren't having periods, so they were kind of just told to go on birth control. And all along, this person's so educated, so intelligent, and they were like, well, what about the metabolic impact of this condition for me? And it was always sort of, oh, yeah, don't worry about it. Don't worry about it. So now here we are, sort of 20 years later in this individual's journey, and we're meeting for the first time and going through their history. And I talk about, the different options to navigate sort of that metabolic aspect of things that they're dealing with. And she says to me, I know that metformin was an option, but you are the first provider to actually acknowledge that for me and actually offer it to me as a treatment option.
Yeah.
And because she's like, my biggest fear is getting diabetes. I've seen the sequelae of what happens to someone with uncontrolled diabetes. And she's like, I'm worried about that for myself. And again, just hearing her story of what she had to go through when she was trying to get pregnant. And we know individuals with PCOS, because you don't ovulate, it is more challenging to become pregnant. But again, for whatever reason in society, we make women jump through hoops before they can get the treatment. Like, we really have to prove ourselves. We have to, keep trying. Try for a year before you can get to fertility treatments. Try for, you know, you have to have 3 miscarriages before you get to this point. So why do we allow women to suffer so significantly when they know that there's something that can present a challenge? And sure, again, in Canada, we have a publicly funded system, and sometimes getting referrals can be challenging. But the hope is that individual, while they're trying, they get pregnant and they don't need your services anymore. But why can't they be on that list in the meantime? I was thinking of it this way. It's like, I treat men as well. When men come to see me and they have erectile dysfunction, I don't say, okay, well, can you kind of still get an erection and maybe like just try a bit longer and see, and then come back to me if like it goes away completely, and then I will prescribe your, Cialis, Viagra. No, I believe them that they have erectile dysfunction, and I give them the medication to treat their condition.
Yeah.
But as women, we say, oh, well, can you jump through a few more hoops and just like prove to me that you really deserve this referral or you really deserve this treatment? So yeah, I know I went completely roundabout to say PMOS, I think, is really going to make a difference. I do think it's a bit of a mouthful. I feel like maybe we could have had like something a little bit easier to say, so that, it was better to market, or it was cooler to say. But I do think it really like summarizes that there is a huge metabolic implication behind this disease process, and we need to consider that.
Yeah, and I think I think they did have a marketing team on there's an interesting bit of research that was done that was released this month, June of
Hmm.
2026, that I haven't read the whole paper, but I understand that there was the marketing people were involved in that, which I thought was really
Oh,
interesting.
cool.
I know, so it's going to have to be, I just looked at it this morning just to have a peek at whether or not I got the words right. My sense is, Shelby, that with something like formerly known as PCOS,
Hmm.
it's PMOS. Yes, I wrote it down
Yeah.
here. Part of the problem with, tell me what you think about this line of thinking.
Hmm.
Western medicine loves black and white, clear diagnoses, A
Hmm.
plus B equals this medication, this procedure, whatever.
Yeah.
But when we're talking about things like polyendocrine metabolic ovarian syndrome,
Hmm.
when we're talking about perimenopause, that there are 103 documented symptoms of,
Hmm.
okay, 103, that's bananas. Medicine just goes, well, I don't know what to do with this. So
Yeah.
go home and have a glass of wine and have a bath before bed, or it's just part of aging, or
Hmm.
have a massage or some other horse shit. Like, can you imagine a
Yeah.
man who's got an erectile dysfunction being told to have a massage? Well, that might actually work, but that
Yeah.
wasn't a great example. But to have a glass of wine and relax, and then maybe he can achieve his orgasm, like bananas when you
Yeah.
think of it that way.
Yeah.
What are your thoughts?
Absolutely. Yeah. I think that medicine really likes guidelines because guidelines keep us safe, right? It's like if you're at a bowling alley and you have those guardrails, like it keeps you in line. And I think guidelines are fantastic, and especially for newer practitioners when you're really sort of navigating what medicine is and how do I practice. But when you start to look beyond guidelines and you look at the latest research and you understand the nuances of things, and that every individual can't fit in the box of the guidelines, that sometimes we need to look outside of that box and we have to be more innovative. And as you know, our system is set up to be very reactive, not proactive, right? So a lot of these guidelines or these, protocols that we have are very much more reactive based. And I think that these, again, like PMOS, for example, significant increased risks of things like diabetes, cardiovascular disease, breast cancers, endometrial cancer. There's a ton of things that at play for those individuals. And how do we not acknowledge that and then help those individuals make informed decisions for themselves? So looking at, your metabolic blood work early on. Like, you might only be in your 20s, but sure, let's look at your cholesterol. Let's look at your fasting insulin, your fasting glucose, your A1C, and let's give you some options of, yes, lifestyle things to do, but maybe you do need medications, because no matter what you do from a lifestyle perspective, you do have an underlying metabolic condition that is going to be challenging to sometimes, for a lot of people, deal with from lifestyle alone. Because what I see in my practice is a lot of shame, a lot of guilt, a lot of I but I work out 5, 7 times a day. I couldn't work out any harder. I eat really clean. Yeah, occasionally I like to get a Dairy Queen, but like, shouldn't I be able to enjoy a Dairy Queen from time to time? Like, and then I go to a provider and they're like, "Oh, you need to lose weight." And it's like, I can't do any more than I'm doing. Otherwise, I am not living. And helping people understand that this is not their fault. Like, they likely would have significantly worse outcomes if they weren't putting in the work they're doing now, because we probably would see a lot worse metabolic outcomes if they weren't exercising, if they weren't eating healthy. But sometimes we just need medications, supplements, other types of therapies that you wouldn't be able to achieve necessarily on your own to meet the goals that you're hoping to achieve.
Yeah, absolutely. Well, I mean, this is a beautiful segue into a conversation that you and I have had a few times, which
Hmm.
is, where does the role of the GLP-1 medications fit into the menopause stack, if I dare call it
Hmm.
that? And
Hmm.
as somebody who knows quite a bit about this very thing, I can tell you it's been an important part of my stack. So, what
Hmm.
have you seen? What kind of conversations are you having around that?
Yeah, I'm a big fan of GLP-1s. I think there's a lot of great research on them. I think when used appropriately under the right supervision, they're fantastic tools. I think where they get a bad rep comes from people not using them necessarily in the way that they're intended to be used, and under probably not the greatest supervision. Um, but we know the research shows us that from a weight management perspective, hormone therapy, like menopausal hormone therapy plus GLP-1s, is superior than either of them on their own.
Say it
And
again, please. Say it again.
yes, so GLP-1s plus menopausal hormone therapy are superior in terms of weight loss compared to each one on their own. And we know menopausal hormone therapy can't be indicated for weight loss, but we do know that when hormones are optimized, or you know put back to sort of a normal physiologic level, we do see body composition changes. I will say, and this is, again, this is my experience, this is something, a pattern I see in my clinic, but I've been saying to patients recently, I feel like three things are kind of universal for women throughout the perimenopausal menopausal transition. And it's not the hot flashes and night sweats, it's weight changes to some degree, libido changes, and the not feeling like myself.
Yeah.
And how those three things impact people is so different. Like some people come to me and they're like, oh, I couldn't care less if any of that changes. But some people it impacts them quite significantly. But I think across the lifespan, women going through perimenopause will, and I don't care what the data says or what the guidelines say or what anyone says, because what I see in practice, that is data as well. And
Mhm.
I have a number of women, like I said, across that, span of perimenopause to menopause. It seems like it's universal that they all experience some element of weight changes despite anything else that they're doing in their life. So I think when we have a tool like GLP-1s that can help reset that needle or kickstart things again, because it can be, again, going back to the whole shame, guilt. It's like, what am I doing wrong? I've done all of the right things. I'm doing all the right things. Nothing else in my life has changed other than I'm going through a crazy hormonal roller coaster. But
No big
you,
deal. Just
no,
perimenopause. No big
yeah,
deal.
just perimenopause, just this crazy emotional roller coaster. But I have so many women who have really prided themselves on their work ethic, the discipline and lifestyle that they have,
Mhm.
and then going through perimenopause and menopause, they struggle to maintain that body image or that body composition that they want or that they're striving for.
Mhm.
And these tools can really be helpful in navigating that. And not to mention, we know there's significant metabolic changes that happen during that hormonal shift. So looking at, is this beneficial because it's going to improve our insulin sensitivity? It's going to reduce our risk for type 2 diabetes. There's cardiovascular studies, there's kidney health studies on this. So there's a ton of great other health benefits. And
Mhm.
as you know, not only
Mhm.
that, it's the things that I hear from a mental health perspective, like the food noise disappearing, that preoccupation with food that we don't even realize because it is a shameful thing and we don't talk about it enough because that's how we feel. We feel like it's shameful when we talk about food and it's hard for people to admit that, like, I spend a lot of time in my brain thinking about food and guilting myself about what I just ate or thinking about snacking. And it
Mhm.
is very, very rewarding to see how much of an impact this can have on someone when they take that noise away and they say, Shelby, for the first time in my life, my brain is quiet and I didn't know that was possible. And it's just like the most like, I can't
Yes.
believe I can't believe how profound and life changing these medications can be. So I think they are a really great tool in that toolbox of medications.
Yeah, absolutely. So, first thing I want to say is that we just have this culturization of women that we are to blame when our waistline gets thick. And that
Hmm.
started for the generation that's in perimenopause and menopause newly now. That started for us when we were in our 70s and we were watching our mothers use laxatives for weight control or
Hmm.
fen or whatever other crazy thing, or taking all the fat out of our diets or all of that other stuff. So, I watch women do this all the time, is sort of hook into that old system. We so easily go back into that old system. And so,
Hmm.
as you said, you talk about the shame and all of this, and I'm doing all the things, but nothing's changing the way it used to. I mean, it used to be that we did an extra workout or we skipped lunch a couple of days and our pants fit better by the weekend when we were going out.
Hmm.
Like, those tricks don't work anymore at midlife. They just
Hmm.
completely stop. And I think you've said something really profound, and I'd like to share my own experience a little bit here,
Hmm.
which will this will be the first time I've shared it on the show, Shelby. So this is a big deal. So thank you for
Hmm.
being the safe person that I can look at while I share the story of my
Hmm.
own GLP-1 journey, which has been almost 2 years. And my first experience with it was my brain went quiet too. And I know I've shared that story with you.
Hmm.
And I have had an anxious ticker tape like brain for as long as I can remember. And I didn't realize, first of all, I didn't even know about food noise. I didn't know that was a thing. And until it was gone. And then it was like, oh, is that what that was? All that
Hmm.
constant anxiety was actually somehow connected into the food system, dopamine seeking system, etc. I hope somebody's studying that for God's sakes, because for
Hmm.
mental health, even more than metabolic health, which has also been extraordinary for us. So I think that's really important for women to hear that. And as I have done on the show now for 11 years, when we talk about the things that are normally in the dark, when we talk about the things that
Mhm.
have been shameful, like weight, like sex, like
Mhm.
assault or trauma or any of the other things that we talk about openly on the show, it doesn't have power over us anymore, and we have
Mhm.
agency. So
Mhm.
thank you for being the segue into me sharing a little bit there.
No, thank you for sharing that story because I know we have talked about that personally, and I just think it's such a beautiful story, and it's just such a great example of, what I see day in, day out. So, I thank you for,
Yeah.
yeah, sharing that. I'm sure your listeners are really going to appreciate that.
I hope so. I just had this big conversation with a patient yesterday. It ended up being like a half an hour long conversation because, again, women's medicine you cannot
Mhm.
do in a 7-minute visit. It just doesn't
No.
happen that way. And she had just been prescribed one of the GLP-1 medications. And of course, I just want everybody to hear what I told her, which is that, and Shelby alluded to this, with the right conditions and the right information, these are such a helpful tool. But one of the
Mhm.
pieces that gets missed is the importance of not pushing high doses, because then you have
Mhm.
the problem of muscle loss and bone loss if you do it long enough.
Mhm.
And that's a big deal because muscle is our longevity organ. So we
Mhm.
want as much to maintain as much as we can now. And we're in our 40s and
Mhm.
50s. This is when we're maintaining it. After this, it gets really hard to put it back on. Okay. So we
Mhm.
want to maintain it. We want to keep those protein levels up. We want to make sure to doing weight resistance training, etc. But and this is what I said to this patient. I said, you have to understand your doctor who prescribed this medication for you got zero training on nutrition, not
Mhm.
because, I mean, it was just left out. It wasn't part of the curriculum. Well,
Mhm.
why didn't she tell me I just need to do this? I'm like, yeah, she just doesn't know. You just have to know where to ask the questions of. So I'd love to hear your
Mhm.
thoughts on that.
Yeah, no, you bring up a great point because I say any of my patients will know that when I prescribe these medications, I have a couple non-negotiables, and one is ensuring you're getting enough protein intake because your appetite goes down. You're less likely, you're not as hungry, so you're not eating as much. So you have to really make sure that what you are eating is good whole foods. And again, enough protein, enough fiber, because we already are usually fiber deficient in the first place, let alone when we're not getting enough intake. And weight resistance training. I know that that can be really challenging or daunting for a lot of women because that's not, again, going back to the generation of aerobics classes and strength training wasn't the like cool way to work out. That just wasn't it, right? So I like to try to, again, use the tools in my toolbox, have the people like yourself that can provide some of this education because you're right. Nutrition's not my area of expertise, nor is counseling someone on exercise prescription either. But I at least can educate enough that these are things someone needs to look into.
Yeah.
And with, as long as someone has the means and ability to be able to source other experts and build a team. My ideal situation is having a patient on these is having them build a team around them that supports that nutrition piece, supports that physical activity piece and the mental health piece. And then, I can do the prescribing piece. But if we can have more of that team approach where everyone fills in the gaps of where they're
Mhm.
comfortable, then we have a better, holistic approach to that care. But I am very, very cognizant of the fact of, again, muscle is metabolically active. It is our longevity organ. It isn't so important. And when we have rapid weight loss, we often lose that, and that's detrimental. And that's where we see some of the, in the news, we hear about Ozempic face, and we hear all these, celebrities and people get really fearful of these medication. And a lot of that is from the more rapid muscle wasting
Mm.
that we see.
Yep.
And the other
Yeah.
thing, I've had patients who've said to me, I have a friend on Ozempic or Mounjaro or whatever, and well, they just think it's a magic weight loss medication. So they just, they haven't changed anything about their lifestyle. They eat fast food all the time. They don't exercise. And I always am very clear that it is not a magic weight loss medication
Mhm.
in terms of getting the
That's right.
outcomes that you're looking for and from the health perspective you're looking for. You have to put in the work yourself. And especially because most of these, we know obesity medicine, as we call it as a specialty, needs to be viewed more as a chronic disease because it is a long-term thing that often, accumulates over time. So oftentimes you have to be on these medications long term, the same way you'd be on a diabetes medication or a thyroid medication. But for some people, they do want to try coming off of it. And I always say, in order to have success coming off the medication, you have to have built foundational habits that will help support you when you come off that medication and you don't have that diet suppression, or the food noise starts to turn back on, or whatever it is. You need to have things in place to help you address those things that became probably foundational to why you started to gain the weight in the first place, or helped contribute to that weight gain. Because if we don't have something in place to support you, you're going to struggle to come off of those medications for sure.
Yeah. Well, and I think obesity medicine is making huge strides because of what we're seeing from people taking the GLP-1 class of medications. And, what I like to say to my own patients is, well, if it was a blood pressure medication, you wouldn't stop taking it after your blood pressure went normal. Like, you have to look at it like,
Yeah.
but that's just the mentality of weight loss. Well, listen, this
Yeah.
is this is healing metabolic disorder. And
Mhm.
when you come off the medication, you're going to return to the metabolic disorder. That's been around your whole life. That hasn't been a
Mhm.
matter of,
Mhm.
eating too much McDonald's or whatever. By the way,
No.
speaking of nutrition, I read
Mhm.
this morning that apparently the soccer team, football team from the Netherlands sent in their own food to the United States because the team was not willing to eat the ultra processed food available in the US. Isn't that
Wow.
fascinating?
That
Something like
is fascinating.
so too. Something like 10,000 pounds of their own food from the Netherlands. Yeah. I mean, if that
That's
doesn't tell
crazy.
you something. Anyways, okay, let's come back. So thank you for that information on the GLP-1s. I think there's such an
Mhm.
important part of the menopause stack for the women that have a metabolic dysfunction.
Mhm.
And there's so many women, like you see it in your clinic, I see it in mine, that it's a game changer across
Absolutely.
the board. Yeah. Okay, so you and I are both huge fans of Dr. Rachel Rubin. We've had
Mhm.
quite a few conversations where her name comes up, and she has
Mhm.
a brand new episode with Stephen of Diary of the CEO. That I
Mhm.
sent. Did I send it to you this week? And then we started.
Yes.
Yeah.
Yeah.
Okay. Frankly, the minute she shows up on a big podcast, I put everything else down and I'm listening to it
Mhm.
because it is a way of dispensing information that has
Mhm.
been in the dark for so long.
Mhm.
And I would like us to dive into some of the topics that she and Stephen discuss in this particular episode. Now, I'm not all the way through,
Mhm.
so you're safe. I don't know if you've listened. Have you listened all the way through?
I've listened all the way through, so yeah.
Okay. Okay.
Yeah.
So if I miss something really juicy, you'll have to bring it up and we
Yeah.
can discuss it. I know yesterday I text you when I heard her say this. I'm like, oh my God, did you get to that point where what she says is only 1.7% of women who go to their doctor for help about menopause are actually
Mhm.
prescribed hormones?
Mhm.
1.7%. How is that happening still, Shelby? What's going on?
It's still the generation that grew up in the shadows of the WHI, so the Women's Health Initiative study, the fear, the lack of understanding, the information, the not understanding the differences between different hormone therapy options. I know people get kind of upset with the marketing term bioidenticals, but bioidenticals are just simply a compound that's similar to what your body produces, and the synthetic formulations and the different risks and benefits of each of those types of formulations, the different risks and benefits from how you take a hormone, whether it's transdermal versus an oral. And I think a lot of that is a lack of confidence in the research and understanding of the research. And I don't like to make excuses, but the fact that we only have, 10-minute appointments in our standard public healthcare system here in Canada, like you said, you can't have those conversations. Like, my intake is an hour because I really want to know you and your goals, because where I start you on that hormone journey really depends on your goals, because not every hormone addresses every concern the same. And so depending on what it is you're coming for, maybe we start, with progesterone rather than estrogen, or we start with only testosterone, or, whatever the case may be. And I think, unfortunately, in those shorter appointment times, it's really set up to guidelines, check off the checklist, not individualize this care in such a unique way. And hormone therapy is really an art. There's science, but there's also an art to it. And so I think we just struggle from a time management perspective in general clinics to provide that art part of medicine.
Well, and we need to talk about the vacuum of training for the medical
Hmm.
professionals too, right? And
Yeah.
I remember reading a statistic a few years ago, which I do talk about on the show quite a bit. Like gynecologists, by their own polling, say
Hmm.
that only 1 in 5 of them, 20% of gynecologists, women's health practitioners,
Hmm.
actually feel confident enough in their knowledge about menopause to speak to a patient about menopause,
Hmm.
which blows my mind because in our system here, we're in the same city. So Shelby and I can talk
Hmm.
about it. What happens here in the city that we're in is that a woman will wait a year or 18 months to see a gynecologist, only to be
Hmm.
told that the gynecologist can't prescribe HRT.
Hmm. Hmm.
So, and I just want to add another note here, and then I'll love to hear your thoughts on it. But I've shared the story on the show, so my listeners have heard me say it. But I have a patient here in town who was having the issue of vaginal dryness. That was her only symptom of menopause. Okay, how easy is it? You and I know how easy is it to write a
Hmm.
prescription for vaginal estrogen? It's not a big deal. It's not expensive. It's easy to access. It's a safe thing. Anyways, she went to the GP. The GP said, I have to send you to the gynecologist. She waited over a year to see the gynecologist. The gynecologist said, patient said, I have vaginal dryness. Can you prescribe me HRT for that? And the gynecologist said, only if you have. My college says the only time I can prescribe you hormones is if you have hot flashes. And my patient did not miss a beat. She said, I'm sorry, doctor. I forgot to tell you I have hot flashes as well. And the gynecologist said,
Oh
okay,
my.
let me write you a prescription. This is the kind of fuckery that we're up against in the
Hmm.
system. So I just want
Yeah.
to add that in so that you've got the context of that. I have talked
Hmm.
about it on the show, but that's just an example of the kinds of crazy things that we hear every day.
Yeah, and I think unfortunately that it's true. I have a friend who's a gynecologist who I immensely respect and I send a lot of my patients to. And I remember us having a conversation and again, trained here in the city, in recent years. So you would think and hope that they would know, but has acknowledged and is very has no ego and is able to say when they don't know something. And they said, we don't get this training. I don't know about menopause the way that you know about menopause, And so unfortunately, I think because they're women's health experts, we expect them to know that, but that's just not where the bulk of their training goes. A lot of it goes into, again, surgery,
Mhm.
pregnancy, and
Reproduction, yeah.
reproductive health. So again, I think we also need more providers that can admit that they don't know something. I do it all the time. And
Me too.
that's where the phone a friend comes in, and I get to use those specialists and those resources. And we collaborate quite well. Like this gynecologist, I send a lot of my patients who need, an actual gynae consultation, whether they had bleeding postmenopausally or et cetera, et cetera. And they will send them back to me to continue to manage their hormone therapy because that's just, again, not their area of expertise. And it's just not a good use of their time either. Right. So I think that fortunately, individuals like Dr. Rachel Rubin and, Kelly Casperson and, Vonda Wright and all of these big names in the menopause world that are being loud about women's health and what the research says, that's going to be what changes the trajectory because we can't expect gynecologists to take it all on because it affects every system. You named out 103 we're up to with
103,
symptoms.
yep.
So
Mhm.
everyone needs to be aware of menopause. If you're treating women, which everyone, every specialty touches on women, even urology, we think of it as a male specialty, but women need
But
urologists as well.
why? But why did
Yeah.
we do that, right?
Again, I have no idea, but every specialty touches on women at some portion in their career, and they have to have an awareness of what women need through this midlife transition because every woman is going to go through this if you live long enough to go through it. So we need to educate more people. People need to be curious and seek it out and understand. Or if you don't have the time and you don't have the desire, have those friends that you can call on to say, hey, I've got this patient. I don't feel comfortable prescribing to them. Can you see them? And again, it doesn't have to be these long wait lists in some of the, like seeing a gynecologist, because their times are getting even longer and longer. But just find those resources in your community that you can use to help connect your patients, because you are doing disservice to them when you say to them, no, you can't have this, without good reasoning behind why you can't have this. Again, I think women deserve to make decisions that work for them. And who am I to tell you that one risk is more important than another? So, going back to, I've had patients denied because they have a family history of breast cancer. We know that's not a contraindication anymore. Even now, we're starting to see the tides turn, and I will love to see how this sort of trajectory goes. But even looking at breast cancer survivors, allowing them to make informed decisions for themselves, because yes, there is potentially, again, that risk of reoccurrence of breast cancer. They already have that risk as being a breast cancer survivor. But being hormone naive also has its own risks of cardiovascular disease, osteoporosis, also quality of life,
Alzheimer's. Yes.
Alzheimer's,
Yep.
quality of life issues. I have heard Dr. Avram Blooming lecture on this and his wife's own experience, which is quite fascinating, and how she was fine with all of the symptoms until she started to have that brain fog and couldn't remember. And she was a very intellectual individual. And she said, I can't deal with this. And she advocated for herself and, had the support and means to be able to do that. But again, why I think all women deserve the right to make a decision once they are truly informed and they really do understand what the risks and benefits are. And then they can choose for themselves what they feel is most appropriate so that they can live the best life that they want to live.
Absolutely. Amen. Absolutely.
Mhm.
Vaginal dryness, one of the most common symptoms of perimenopause and menopause, and one of the least discussed. So many women are quietly suffering through it, thinking it's just something they have to accept. It's not. You do not have to white knuckle your way through discomfort, painful intimacy, or that constant feeling of irritation that nobody warned you about. There are solutions, and today I want to tell you about one that has genuinely caught my attention. It's called Melt for You, and it's the newest product from Womanness, a brand built specifically for women navigating menopause by women who get it. Melt for You is a vaginal insert, hormone free, which means it's safe to use whether you're on HRT or not. And there's no applicator, no plastic, no fuss. Just a small suppository you insert at bedtime every 2 to 3 days. That's it. The star ingredient is hyaluronic acid, the same moisture binding powerhouse we love on our faces, working from the inside to deeply hydrate vaginal tissue, restore elasticity, and calm inflammation. It also contains lactic acid to support your vaginal pH and the health of your vaginal microbiome. Womanness spent 2 full years developing and perfecting this product, and that care shows. Most women notice a softening and soothing effect within the first day or two. By 2 weeks of consistent use, moisture levels are restored. There are 7 inserts per box. That's 2 full weeks of hydration right out of the gate. Head to womanness.com, that's WOMANESS.com, and use the code LOVELY to try Melt for You for yourself. Because comfort in your own body isn't luxury, it's something you deserve every single day. I talk about Avram Blooming's book, Carol Tavris as well, called
Yeah.
Estrogen Matters on the show quite a bit. So Shelby has just talked about listening to Dr. Blooming speak live, which has got to be quite the pleasure, because he doesn't do that very often anymore, I don't think.
No, and he is one of the kindest individuals. I saw him in March at the Harvard conference, and yeah, just he's again a trailblazer in terms of looking at hormone therapy and options for individuals who've suffered breast cancer, and even just I've had patients recently, if putting the whole systemic hormones aside, but the vaginal hormones. And we know that that's safe in breast cancer survivors. And they're still being denied that treatment and care. And it is extremely frustrating because, again, it's a lack of knowledge, a lack of understanding. And I hope that with conversations like this, we can disseminate that knowledge more and people can get the care that they need.
Yeah, absolutely. So I'm going to tell a story about a patient who went through a breast cancer experience a few years ago now and was miserable. I think this is before you and I met. Actually, I know it is
Hmm.
before we met. She was quite miserable with symptoms after she had been through treatment, which was successful for her. And she said, I'm just being told no. I want some hormones. I'm just being told no. And I said to her, I said, I think what you have to do is you have to go back to the oncologist and ask them who they will, because everybody else is going to say no
Hmm.
until the oncologist signs off on it. So she did. She
Hmm.
went back to the oncologist. This is here in Calgary. And
Hmm.
the oncologist said, I've got one gynecologist that will prescribe hormones for someone who's been through breast cancer. And don't be alarmed. He also happens to be the guy that does the sex reassignment hormone transition
Hmm.
prescriptions.
Hmm.
Well, that was not a very good thing for my patient. She got what she needed out of it, but it was
Hmm.
like, really? Now listen, I'm not saying that there's an issue with that. I don't have any problem with that. You decide what your gender is going to be. That's a thing. That's fine.
Hmm.
But isn't that fascinating that
Hmm.
that is have I shared that story with you
No.
before? It's quite
But
something,
you know
isn't it?
what I think is actually fantastic for our field is the research that we have for trans men, because we are putting trans men, so obviously biological females who want to transition to males, on very high doses of testosterone
Yep.
and super physiologic levels of testosterone far beyond what we would ever prescribe to a female in perimenopause, menopause, or symptomatic low testosterone. And we have great safety data from that population. And so it's really, I think, fantastic because this is an area where these individuals are choosing to go on super physiologic levels. We are researching it. It's the data is fascinating in terms of the safety, and so I think that that's going to be an area that allows that testosterone conversation to evolve for women.
Yeah, perfect. I love that. We'll use the data as we get it. So
Hmm.
what Shelby is saying is basically if my testosterone dose, which is 25 milligrams, I think it is, it's going to be different for everybody, or is that a standard dosing for women in perimenopause? Is
It
it
really
different?
depends, I guess, on the method of administration. I mean, I usually start patients with a cream at like 5 milligrams a day, and then we titrate from there. But yeah.
Okay. So what you're saying, and that is a therapeutic dose for perimenopause, but a physiological dose for a biological female who wants to become a male is much higher. And what you're saying is the research is showing that even with these much higher doses that you're calling the physiologic dose, it's still a safe thing for us to do. So
Mhm.
we're going to be able to extrapolate our own safety profile from that, which is great.
Absolutely. And I think, the beauty in that is that these individuals are choosing to have that treatment, and women should be able to choose to have the treatment with testosterone for symptomatic improvement as well. But for some reason, again, when it comes to women's health, we always have these barriers and these loopholes and these jump through. And we just obviously oftentimes assume women can't, again, take medications as they're intended, or avoid pregnancy if they're on these medications. So, yeah, it's an area of research that I think is going to make a huge impact on women's health overall for
Yeah.
testosterone.
Which is great because we need to have that testosterone conversation. I get asked about that probably daily
Hmm.
from women that I'm seeing in the clinic because they want to know. First of all, they always want to know if I'm taking testosterone and they want to know what I
Hmm.
think about it.
Hmm.
And so I think more education about the importance of testosterone being part of the menopause stack, if I'm going to be cheeky enough to call it that, then
Hmm.
because that's probably a question you get asked quite often too. Yes.
Yeah, I love testosterone. I think it is underutilized in women. I don't know why we gendered the hormones, estrogens for females, testosterones for men. We get both. We both have both, and they're both important. And as your listeners are probably well aware, women actually have far more testosterone they're circulating in their body than estrogen. And it's independent of menopause. It starts to decline in our 30s, and it's a motivation hormone. So not just motivating for sex, but motivating that get up and go, that drive, that desire to complete tasks or achieve something. And I often hear patients sort of describe it. It's a very vague thing, but I've seen it pattern time and time again, where they say, I'm just kind of like I couldn't be bothered. I normally was like, I'd jump out of bed and I'd go to the gym and I'd do all of my work tasks. And I was trying to run, be president of this organization and coach my kids' soccer and do all this. And now I'm just kind of like, whatever. I couldn't care less. And that's not me. And it's amazing what supplementing testosterone back to, again, a physiologic level for a woman can do in terms of improving those symptoms. And I had a patient recently, actually, how she described it was that I felt like I was unplugged and someone plugged me back in again, which I thought was so cool.
100%. Yep.
And again, why are we not acknowledging this hormone that is so vastly important, not only for the things that I mentioned, but heart health, bone health, brain health, muscle building,
health. Yep.
our libido, which can trickle down into relationships. We know actually vaginal testosterone, there's some really great data coming out about how that can be really important for the genitourinary syndrome of menopause and pain with sex and vaginal dryness. And I think that when you treat enough women, because right now the guidelines really are only for hyposexual desire disorder. So low libido, someone has to be bothered by it. It has to be, a certain period of time that you've experienced these symptoms. It has to be significantly distressing, which again, we're making women jump through so many hoops to get the testosterone. I've even had patients recent as last week say to me, I went to see a provider. I was wanting to talk about testosterone because of all the research I've done. And they said, well, are you sexually active? And they said, well, no, actually, I'm not. And they said, okay, well, if you find a partner and that becomes something you want to consider, then we can have this conversation. And I just thought, why are we again just chalking testosterone up to a sex hormone? Yes, it is the sex hormone technically, but why are we just assuming its only purpose is for sex drive? And it's not. Again, motivation, drive, desire, and that includes libido, but it includes so many other facets of our life.
Yeah, absolutely. So my own experience with the testosterone, for those who are listening, was that I felt just flat. Exactly what you just described with your patient. She was unplugged. I think I actually fell off the estrogen cliff, and that was part of what happened at that time. And I just kind of went flat on everything. And that is not, I'm a fairly flashy individual. And for me to just go flat on things, it was like, what the hell is happening? I don't like this. And when I saw my own nurse practitioner about this, I thought that was going to be the time that would tell her it was time for me to start taking estrogen, systemic estrogen. And she said, no, when a woman loses her confidence, that's a testosterone problem. Let's take a look. And sure enough, my estrogen was still good, but my testosterone had gone low. And so I started taking testosterone before I started taking systemic estrogen and progesterone years before that. But I just think and for me, it was exactly as you just described with your patient. It's like someone just like one morning, like the curtains open and it was like, she's back, and, give me a runway. I'm back on. Right. And that was testosterone for me. And I suspect that's a lot of other women too.
Yeah, I would say I always tell people because I find estrogen and progesterone, if they're going to fix a problem, it's pretty immediate. And for some people, testosterone is like that, light switch goes on, that plug is plugged back in. And then for other women, it's a bit more of a slow burn. Like they don't notice something, but 3, 4, 5 months later, they're like, there it is. I'm starting to feel better. So for everyone's experience is so different. But again, when testosterone is the issue, it can be so profoundly impactful, and we deserve to acknowledge its benefits greater than just improving libido and sexual function. It does a great job there. Don't get me wrong. And I think that is a very important part of our health is our sexual health. But if a woman is choosing not to be sexually active for whatever reason, we also need to acknowledge that she deserves that care as well.
Yeah, absolutely. It's such an important part of things. Okay, because we're
Hmm.
talking about testosterone and libido, I want to ask a thing about sexual health here.
Hmm.
I actually think part of the libido, you will experience this, I'm sure, in your practice. Libido's in the top 3 things that I hear about and
Hmm.
have heard
Yeah.
about in all the years I've been talking to women, over 20 at this point, about menopause. And I've always felt so strongly that it really wasn't about just the physical act of intimacy. We
Hmm.
understand so much more now about
Hmm.
libido than we did a few years back, even. But part of what I think happens, and I'd love to hear your thoughts on this. First of
Hmm.
all, we collapse sexual wellness as a whole into something we're calling low libido, number one.
Hmm. Yeah.
But also, we're using a man's libido as the guidepost as to
Hmm.
whether or not, well, if we don't get a boner every day, if we don't, want to have
Hmm.
sex every day, then there's something wrong with us. And
Hmm.
I've always think that that's always been, we need to have like a shift of the lens here. We're
Hmm.
looking at it all wrong. What do you think?
I agree. And I think that for women, I mean, libido is so broad, and why sex starts to change as, we age. There's so many factors. So we have the biological factors, the hormone changes, the changes to the vagina, because if you have vaginal dryness, so there's not enough lubrication, if you start to then have pain with sex, you're not going to desire something that's painful. If you know if we're, again, from the biological perspective, not having that hormones that are going to cause blood flow to the genitalia, we're going to lose, orgasmic function, which again makes something a little less pleasurable. So there's a biological part, but it's biopsychosocial. So, what starts to happen in midlife for a lot of women, we are torn in a million different directions where, we're caretakers for children, perhaps. We may be caretakers for ailing parents. We're in the peak of our careers. So there's a lot of stress there. Our relationship, where's our relationship at? Do we feel safe? Do we feel like, a really interesting thing I heard Rachel Rubin say on that podcast was about scheduling sex. And I know that sounds not sexy, but the analogy she used, which is when you were dating and you weren't, engaged, married, in a long-term committed relationship, you said, "Hey, let's go out on Friday, Saturday night." And in your head, you were like, "Oh, okay, maybe this is going to happen. Maybe I'm going to, get lucky here. We're going to
You're
have
gonna
sex
shave your
this
legs.
night." Yeah,
You're gonna shave
you're
legs.
doing all the prep, and you've got a week leading up to it where you're kind of thinking about it. You're excited to see that person, that builds, and that's kind of in and of itself a bit of foreplay in a sense. And then we get to, this stage of life where you're in a long-term committed relationship, and you're busy. They see you at your worst. You're struggling with, the demands of life. Maybe you don't even feel like the best version of yourself. And so there's a lot of factors that make it more challenging to engage in sex the way that you used to when you were younger. So it's factoring in those things. And that's where, sex therapy can be really helpful. And, really communication with your partner, because that's, I think, a big important part. We have such a connotation with sex being part of a relationship and a closeness, and how we get um, that feeling loved and wanted by a partner. And so when that starts to fall apart, I think that can really impact some relationships. And so again, what does sex mean for you? Why is it that desire is lower? What can we do to kind of help, navigate this, mismatch in libido that can occur between a male partner, perhaps, and a female partner in these heterosexual relationships?
Mhm.
Um, and so I think that there's so many different facets that we're missing. And when you actually sit and talk to a woman in these types of appointments, when you're talking about libido in depth and you're talking about, sex, and it's usually not just one thing. There's usually a number of different factors. And I
Mhm.
always say too, like, if your relationship sucks, if you hate your partner, if they're
Yeah,
mean to you, if they don't make you feel safe, no amount of testosterone is going to make you desire sex more,
exactly.
right? So it's, looking at all of those aspects and trying to help someone take a holistic approach to sex the same way you would any other aspect of health, because sexual health is health. So that's sort of my thoughts on it.
Yeah, I love that. What you've just said. My question to my patients has become over the years is when a woman talks to me about libido, my question right back is, do you actually want to have sex with the person you're with?
Yeah.
And less than half the time, I get an instant response. Because of course, if you do, you'd be like, oh yeah, he's hot. I want to hump him.
Yeah.
But if you don't, then it's like, ooh, how do I answer this question? And then it's an answer in itself, right? Then you go, okay.
Absolutely.
So remember that you can choose intimacy as a way to connect with your partner, but you can also choose to be intimate with yourself, because orgasms are very helpful for brain and heart health. I recommend 3 a week personally. The response I always get from women when I recommend that is, too messy. I don't want to get him involved. I said, you don't have to get him involved. That's the point. You just have to learn your own anatomy. And I love the conversation around the clitoris and pleasure anatomy, which of
Yes.
course we're understanding in a far better way now than we ever have before. Okay.
Absolutely. And I agree with that wholeheartedly, because I think, again, it comes back to education, communication with a partner, because what one person finds pleasurable or desirable varies from person to person. And, we can't expect our partners to read our minds either, right? So when
Oh, but we do. We do. We do.
and that's the thing, when something and men, for example, again, heterosexual relationships, men are simple, right? So if they're engaging in sex with you one way and they see it seems like you enjoyed it, to their ability, they enjoyed it, they're like, okay, that's great. But if you didn't enjoy it, or if there's something you want to change or adjust or do, I mean, sex shouldn't be painful. If it's painful, you deserve an exam to figure out why. You deserve to have pleasure. You deserve to have an orgasm. And I think, again, part of our female anatomy is that most women require clitoral stimulation in order to orgasm. And I think oftentimes women don't even know where that is on their own bodies, because we don't educate women. We do such a bad job of educating women about their own bodies. I think back to when I was in university, I had a friend who, there's a prime example. She would take out a tampon every time she went to the bathroom, even if she just went to the bathroom and just put it in. And I would say, well, why do you take it out? She's like, well, I need to in order to pee. I'm like, oh my goodness, no, we have a different hole for that. But you know what? If no one's ever taught you, if you've never looked at a diagram, if you don't understand, well, I don't know. Why would you think any different? So I think we need to.
This is the clitoris.
Yes.
This is the urethra. This is the vaginal introitus, or the vaginal opening. And of course, the anus and perineum would be here. This was crocheted by a patient, by the way.
I love that.
Isn't
that
it
is so cute.
Her name is Pearl.
I love that. Yeah, no, I love that. And
we don't know. Yeah. We don't know, Shelby. You've made a great point. And I remember having a conversation with some male friends of mine about tampons. They wanted to know about tampons. Like, well, where does it go? Does it go? And I'm glad they asked. One of those guys in particular, I was still in contact with him, and he's got 3 daughters. So I'm glad he's got that sorted out. Because my roommate and I were the ones that said, "Oh, describe to him, this is where this goes," and everything else. But something I think that needs more airtime, and I know Kelly Casperson's really good at talking about this, is we have, something about the hormones, the biological impetus of the hormones is reproduction. I'm talking about in a heteronormative experience.
Yeah.
And when those go away, and let's say we get HRT reintroduced, it's a much smaller amount than what we're experiencing estrogen, progesterone, testosterone when we're cycling, we may realize that penis and vagina is not all that interesting anymore. And then we have to have a bigger conversation about, maybe I'm not feeling like having sex because I'm not really interested in insertion anymore. It's a big discussion.
Yeah, absolutely. And then again, that goes back to that conversation and educating your partner. And again, do not do it in the heat of the moment when you're in the bedroom, because that's so vulnerable. These conversations, like we debrief, like I was a registered nurse first in labor and delivery. And if we had a case, that we could learn from, we debriefed, right? And so as unsexy as it sounds, debrief about, what did you like? What would you like to try next? What what worked, what didn't work, because the reality is that if you are in a safe relationship, the hope is that that person cares and wants you to have a good experience the same way you want them to have a good experience, right? So they are going to be open to your suggestions and things that are going to make you feel good. And again, women barely know where their clitoris is. So how are we expected men to know where that is? And then how are we supposed to educate men on what feels good for us if we don't know ourselves? So it can be, again, a learning experience on your own where you figure that out on your own and then you're able to bring that to a partnered relationship, or you and your partner explore that together. And again, sometimes you're not going to get it right every single time. And you're going to try things that, oh, wait, yeah, no, I know it now. I don't like that. But I think that when you have those safe relationship communications, that those touch points where you're able to really check in and understand what each other wants, it is just going to make that connection more profound. And it's going to make you desire sex more because it's going to feel good for both parties.
Yeah. I love the part of the conversation. I don't know if Rachel touches on this in the episode
Hmm.
we were talking about, but we have always had the experience of desire and
Hmm.
arousal.
Hmm.
But as we get older and that sort of horniness, if you will, goes
Hmm.
away or it declines, this is when you have to, as you were saying, schedule sex. You have to know that Saturday nights are playtime, then you're looking forward to it. And that as we change,
Hmm.
arousal follows the action
Hmm.
rather
Hmm.
than, when we were in our 20s and a leaf blows and,
Hmm.
we're ready to go. Right. So it's very different.
Yeah. And the thing is, too, we know men and women are so different, right? Like women are a lot more cerebral in that sense where it takes a lot more. And just historically, culturally, women carry a lot more of that caretaker burden. So we have a lot more in our brains that is, stressful at any given time, that we really need to be given permission to turn that off in order to now enter this other side of our brain that allows us to relax and enjoy and become aroused and have a pleasurable sexual experience. But we need to have a safe space in order to do that. And we need to have that either partner that makes us feel safe, or explore that relationship again with yourself, but give yourself that time and space to turn that area of the brain off, because it is different. That desire where you aren't actually engaging in sex, but you're thinking about something, or you see something that um the all those shows that are out on TV now, the teen shows, the heated rivalry, the everything else that's kind of driving this, oh wow, I find that person attractive, or you start thinking about how you would be turned on. That's different than, obviously, I have a lot of women who are like, when we get going, I'm into it. But like the thought of getting going, I'm just like, oh, couldn't be bothered if it ever happened again. And if that is a problem for you, or you feel like that's something you want to change, it's looking at, how do I change it? Is it my circumstances? Is it that I'm so stressed day to day? And if I remove some of that stress, I'd feel better. Scheduling it again, would that be better? Or again, is it simply that there's an issue with the relationship, or
Mhm.
so on and so forth, that that's impacting that?
Yeah, it's complex for sure. And I think just putting,
Hmm.
starting those conversations, continuing, you and I continue to have those conversations, and every other
Hmm.
practitioner like us that are having the uncomfortable conversations. Because as I said at the
Hmm.
start here, when this stuff is in the dark, it has power. But when we let it out into the light, then we can start to get solutions to it. We don't feel
Hmm.
shame about it. We can actually get somewhere with it. So, nurse
Hmm.
practitioner Shelby Sheppard, thank you for coming on the show and
Thank you
dispensing
for
your wisdom.
having me. Thank you so much for having me. It's been so fun, as always, to have conversations like this with you. Yeah, I love sharing all of the knowledge that the two of us have kind of found throughout our careers. So yeah, thank
Yes.
you.
Yeah, you're welcome, and thank you for continuing to do the great work. Shelby's seen something like sixty of my patients, my people that I know, and they love you. They absolutely adore you. And your
Thank you.
kindness and your compassion and your willingness to just sit with them and hear the things that other practitioners haven't been willing to hear. So I thank you for that so
Oh,
deeply.
thank you. Thank you.
Yes, you're welcome. Okay. Shelby, where can people find out more about you, please?
So Instagram, pause, PAUSE underscore health is my Instagram, my website, pausehealth.ca. And yeah, that's where you can find me.
Okay, fantastic. Thank you. So I have a final question I ask all the guests that come on the show that I'd like to ask you now, if you're okay.
Yeah, absolutely.
Okay. Knowing what you know now, what would you tell your younger self?
Ooh, that is a great question. Ah, what would I tell my younger self? I would tell my younger self that you need to be comfortable with uncomfortableness and need to be able to put yourself out there in order to grow. I think sometimes I, as a younger person, was a bit uncomfortable being vulnerable and not knowing the answers to things or admitting that I didn't know something. And I think now I recognize there's so much I don't know, but people really respect your ability to say, I don't know that, and being curious and being able to go against the grain. Because I think when I was younger, I didn't really have the confidence or experience to be able to stand up to some of this stuff, especially because as a nurse practitioner, there is a bit of that hierarchy sort of view. And I would tell my younger self now to trust my gut, to be curious, to listen to people, to be kind. And ultimately, that's what's going to matter more than anything else in the end.
Yes, ma'am. I love it. Dispensing wisdom right to the end. Nurse Shelby Sheppard, thanks for coming on the
thank,
show.
thank you.
The information and other content provided in this show, or in any linked materials, is not intended and should not be construed as medical advice, nor is the information a substitute for professional medical expertise or treatment. We are doctors, but we aren't your doctor. Seek your doctor's opinion. If you or any other person has a medical concern, you should consult with your healthcare provider or seek other professional medical treatment. Never disregard professional medical advice or delay in seeking it because of something that you have heard in this podcast or in any linked materials. If you think you may have a medical emergency, call your doctor or emergency services immediately. The opinions and views expressed on this page and in this show have no relation to those of any academic, hospital, health practice, or other institution. Thank you.